be invited to talk to you guys, and I'm excited to be able to collaborate and share experience as well as information with each other. Just briefly, I'm going to go through the timeline of surgical robotics development. This definitely does not encompass all of the history of robotics development. However, this is just kind of during the last 30 years or so in which it has received a lot of advancements. Initially, it was kind of brought about in the 1960s, 1970s is when people started talking about robotics and how it can advance our society. But it really wasn't until the late 1980s when the Stanford research team, the SRI team, was able to receive funding in order to further advance the research in robotics. That coupled with the military's department, the DARPA, began to allow funding to ensure that there were prototypes to develop surgical robotics. And about 10 years from that time is when the first, the most popular robotic machine that we know of today, the Da Vinci, was FDA cleared in 2000. The idea of the surgical robotics development really came about to assist with NASA, which is the space program here in the U.S., as well as the military, to be able to offer their astronauts as well as their soldiers remote open surgery in the field when hospitals as well as surgeons was not easily accessible for these type of patients. However, they found that it was often useful for laparoscopic surgery and actually a replacement for laparoscopic surgery in areas that it was difficult for those equipment to reach. And then in the 2000s, it continued to have further advancement. The FDA, or the Food and Drug Administration in the U.S., usually takes quite a long time to approve of anything. About 20 years is the estimated average for machinery. However, the robotics actually, within a little bit over 10 years, was able to get FDA approval, which is quite fast. And this shows the need for this type of knowledge and the need for this type of surgical instrument to further advance our medical care for our patients. Over in this picture over here, you can see kind of the first kind of prototypes of what they were trying to achieve with a surgeon sitting at a table away and remotely from the machinery. Today, this continues to evolve into what we see today with machinery that are on the market today for us, but it continues to improve and evolve with multiple potential competitors joining the market and new procedures and specialties that are actually joining in the robotic procedures that they find that you can utilize it efficiently and safely for their procedures. For me, the robot machine that I am most familiar with is Intuitive's Da Vinci. I've been practiced in multiple states at multiple hospitals, and this is by far the machine that everyone favors here in the United States. And I think this is a machine that most surgeons practice and operate on, especially for big abdominal cases, but as well as breast cases, thoracic cases. This by far has a monopoly on the U.S. market. Another competitor that has joined the market is actually the Medtronic Hugo robot. It's supposed to be the direct competitor to the Da Vinci in order to operate on the abdominal compartments also. It's not currently FDA approved yet, although it is approved to be used in some European and Asian countries. Medtronic actually opened up a simulation center in an area where doctors can go and practice in Boston. They strategically chose Boston, Massachusetts to open up their center because there's such a huge saturation of hospitals all in one area. And so by doing this, they're hoping to introduce their product a little bit more and mainstream it in order to compete with the Da Vinci. Other leading robotic competitors, I have only used a couple. I'm only slightly familiar with some of these, but one that's commonly used is Stryker's Mako. As you can see here to the right, it's often used for joint replacements. Other ones listed here, some are for GI procedures such as the EndoQuest. I am used to the Ethicon brand by the Johnson & Johnson for robotic bronchoscopies and lung biopsies. We do often use that for those procedures. But there's other ones listed here, as you can see, for vascular surgery, for robotics, knee, hip, and brain surgery. But again, by far, the most competitive one is the Da Vinci, and that is the one that I see most used everywhere. You can see here, this is just a picture of a common setup of how a robotic room is set up. I just listed out kind of all the surgeries that here at MD Anderson that we do that uses robot. Of course, general surgery with gallbladder removal, as well as hernia repairs, but also all the pelvic surgeries such as colorectal, gynecological, urological. They mainly use robot just because their area is so hard to reach. Thoracic surgery has actually been doing a lot of robotic lung resections. And I know we don't do cardiac surgery at MD Anderson, but I know my colleagues at the hospital across the street from me do. They do valve replacements, even some of the bypass surgeries on cardiac through robot. At MD Anderson, we also do head and neck surgery in the mouth with robotic surgery. And we started doing breast surgery and plastic surgery through robots too, where we can make just a small incision through the axilla instead of doing a huge incision through the breast for these type of surgeries. So it's advanced quite a lot, and it's pretty amazing how much more surgical fields and specialties have started to start utilizing the robot. Advantages to robotic surgery. Some of the advantages listed is it's a minimally invasive approach, so you avoid the huge laparotomy incision as pictured in the picture here. This classical incision, instead, you will have kind of a smaller incision like over here. This is just kind of by default a picture of what incisions might look like. Not all incisions for robotic will look this way, but as you can see, the incisions are quite smaller than the large laparotomy one. And usually less blood loss, less postoperative pain, and a faster recovery for the patients. It's often a better cosmetic appearance for the patient as the scars heal very well and they're small. It's less fatigue on the surgeon physically as they're not bending over the patient constantly, and they're able to sit with good posture at their station. It's also a good option for obese patients that are difficult for poor wound healing, poor access to these patients' abdominal cavities. So it's a good option for them. And again, it's a good option for accessing hard to reach places such as surgery in the pelvis. Limitations to robotic surgery. As you can see in the picture here, we have pretty limited access to the patient once the robot has docked. So once the robot has docked, the arms are tucked at the side, the head is kind of far away from us. We really have no contact with the patient. And so we really want to make sure that the patient is fully positioned appropriately and we have all our lines and everything we need before we dock. Sometimes the machine can malfunction. It often uses Bluetooth or relies on electronic connections. And I've seen before where the robot has actually not stopped working and we had to stop and pause the surgery, pull the robot out and wheel in another one and kind of redock and relink it again. It also requires increased practice and expertise, not just from the surgeon, but also from the surgical team, the scrub techs, the nursing. Can require a lot longer operating room time to set up. It can cost a lot more, not just to us, the facilities, but also to the patient. The setup is quite a bit more expensive. It requires a larger room because of all the bulky equipment, which can impede care in case, there's an emergency and we need to open up emergently. It's difficult to access the patient when you have all this bulky equipment in the way. So it does have some limitations. Anesthesia considerations for robotic surgery, since this is my area of expertise more so than the surgery area. So I'll talk to this a little bit more. In pre-op, when I see a patient, I kind of look at them overall for their health to see if they can handle being undergoing surgery for the robotic procedure. One of the reasons is often for robotic procedures, the patient is in steep Trendelenburg position. And so this is not an ideal position for many patients, especially those with pulmonary hypertension or cardiac comorbidities, where they might do better with open surgery when they're leveled and supine and not in that steep position with their head all the way down. Other things I consider is their weight, to see how we're able to safely position them on the table, how their lung function is, their compliance, if they have good blood gas exchange. I also talk to the patient and prepare them kind of for the positioning concerns for the surgery. I tell them often the length of the surgery is a little bit increased because of the setup and the complex setup that requires. I tell them that because they will be in that steep T-bird position, that they might have vision change afterwards from all the blood congestion. I tell them that edema-wise, they might have some edema in their face, as well as positioning concerns because of how tightly they're tucked and how they're docked with the robot, that there might be some nerve injuries. And so overall, I kind of prepare them just so that when they wake up, there's not really any surprises, especially with the edema in the face. This is often, especially with longer surgeries. Intra-op, usually 99.9% of the time we will do general anesthesia. I have never put someone not under general anesthesia with an endotracheal tube for a robotic procedure. We usually recommend that you have 2 peripheral IVs, ideally in both arms, so that if the surgeon is leaning on one arm or if one arm somehow is inaccessible to us, we can use the other IV. Recommend an OG tube, oral gastric tube or a nasogastric tube to decompress the stomach and allow assistance with aspiration of fluid afterwards whenever we are waking the patient up. Foley catheter in order to monitor accurate ins and outs in the urine output, as well as decompress the bladder for the surgeon. Paralytic, deeper anesthesia to make sure that the patient is absolutely deep for the surgery, as waking up, especially in this position, is quite traumatic. And also, most importantly, positioning, making sure that the patient is adequately strapped to the table, make sure that their face and eyes are padded, so that way when the robot is over them, it does not push on their face or eyes or chest and cause injury. Also make sure that the endotracheal tube is secured in the right place so that it doesn't migrate during the movement of the patient. And also make sure that the arms are tucked appropriately to decrease the risk of nerve damage. Other things that I think about is that cardiac output can overall decrease due to the patient being in that steep T-bird position and the increased abdominal pressure. Respiratory wise, definitely their lungs get affected. The compliance decreases, the FRC decreases, there's increased airway pressures, there's increased ventilation perfusion mismatch. So a lot of times the patient might not be ventilating well and we might have issues with oxygenation. Sometimes we have very obese patients here in the United States, sometimes close to 300 or 400 pounds or more. And those patients, when you're putting them in that steep T-bird position, they often can't handle it. We often cannot oxygenate, and we have to kind of talk to the surgeon and communicate and tell them that we might not be able to do such a steep Trendelenburg position because their lungs are not able to handle it. Other things for those patients is that often we look at the vent settings to make sure that their peak pressures are not too high to cause barotrauma. And so we consider increasing PEEP and kind of a recruitment maneuver prior to the patient undergoing T-bird or insufflation to kind of help with their ventilation. Other things are, of course, with that steep T-bird position, there's increased intracranial and intraocular pressures. So there's the risk of vision loss afterwards, as well as stroke. And then for renal, with all of these cases, because of the increased intra-abdominal pressure, there's always tend to be a decrease in urine output during the procedure. And so the Foley really helps us, but we also keep in mind that oftentimes the patient will not make much urine during this. A quick way that I assess a patient's hemodynamic status is often when they go into T-bird position or they're insufflated for the procedure, I will see how they respond. If it looks like, their blood pressure drops, it looks like they're dry and they need fluids, that's a quick kind of idea to gauge kind of how much resuscitation they need. Here is kind of a brief diagram of things that can occur during a robotic procedure, especially with the common T-bird positioning that they do. As you can see here, as mentioned before, the lungs, airway pressure does increase, compliance decrease. You can see in the heart that the cardiac output does decrease a little bit. but the right atrial pressure increases as well as the SVR. In renal, like we talked about, urine output does tend to decrease. And so you tend to not get that much urine, but it's still very important to make sure that the patient is adequately being resuscitated and perfused. On the other side, you could see with the insufflation during the robotic procedure, you introduce increase carbon dioxide into the body through the insufflation, but also through the fact that there's decreased lung compliance. So the patient is not able to really exhale a lot of this. So as a consequence, you might have some pulmonary vasoconstriction. On the severe end, sometimes you get subcutaneous emphysema when the CO2 kind of diffuses into the soft tissues. On the severe end, you might get a gas embolism. That's always something to look out for. And as you can see here, the heart can also go into quite a few issues with hypercarbia. So it's very important to monitor this and to know the threshold of when to, again, ask the surgeon to kind of level out the patient so that you can kind of catch up on the lung function. And sometimes I've done cases where every couple of minutes, I will have to ask the surgeon to level out, get the patient better again, go back into T-bird position, level out, and it's pretty much just a back and forth for the whole case. So it can be an easy case or it can be quite a difficult case depending on your patient. Complications, I've listed here just a couple of common ones, but of course there are more. Things such as prolonged surgery and excessive fluid can cause a lot of airway obstruction and swelling. And so a lot of times we are, especially for long surgeries, sometimes I've been in a surgery that's been going on for over 13 hours. A lot of times patients can wake up very swollen. Their airway is a little bit scary. It might not seem safe to extubate them. And so we might keep them intubated due to that. There's also risk of gastric aspiration from all that intra-abdominal pressure. Of course, the CO2 insufflation that I talked about earlier with the gas embolism, the arrhythmias that can happen with the hypercarbia, as well as the subcutaneous emphysema. There can also be blood congestions in the face since they are in that steep T-bird position for so long. Sometimes even with just simple, when I put a nasal temperature probe very gently in the nose, when they're in that position, there could be a lot of bleeding, again, just because of all that venous congestion. There's risk of postoperative visual loss, especially the longer you are, the longer the patient is in that T-bird position. There's nerve injury, of course, hypothermia due to difficulty kind of reaching the patient and covering them fully to be warmed. This guy over here, I've had patients that look like this before, like in A, when they kind of wake up, or at the end of surgery when they're just completely swollen and their face has doubled in size due to the CO2 kind of going into their skin. And if you feel their skin, it almost feels like crackles. Oftentimes it will resolve on its own. Sometimes we extubate if we feel safe. Sometimes we leave the patient intubated and move them to PACU and extubate them a couple hours later. It's just kind of patient dependent. Eventually it goes away when they sit up, but it is something for concern, especially if they're hemodynamically unstable. You might want to check, like chest x-ray for pneumothorax. You might want to do further heart workup in case they have hemodynamic instability. So it can be mild, but it can also be quite severe. Main points really of this talk is that robotic surgery has advanced quite fast in terms of medicine from when it was founded and discovered to when it achieved FDA approval, as well as being approved to be used worldwide. It really only took 2 decades, which is pretty fast for surgery. And so that just shows that there is a need for robotic surgery. There is a need for the advancements in this in order to help our patients and kind of advance in what we know. Other really serious things that we should consider during these are positioning. That's really critical. Really, that's the main part, is making sure that they're positioned correctly before the robot is docked, because after it's docked, we're pretty much kind of stuck in that way. Not permanently stuck, of course, we can undock, but really the ideal part is just to make sure the patient is completely positioned safely. You have all your lines, you have all your endotracheal tube and everything secured correctly before you proceed. Other thing is to make sure that communication amongst the team is the most important. I've definitely had cases before where I've had to ask the surgeon to kind of stop so that, like I said earlier, so that we can level the patients to make sure that the patient's stable. Also, the surgeon has also told me that they need to level the patient and to open up the patient if they run into bleeding or something that they can't control robotically. And so a lot of times, as long as the team in there knows how to communicate and to work together, a lot of times things can be safely done with robot, and the patients can often go home quite fast and soon after these surgeries. And here are some of my resources.